Hello, my name is Naomi Iron. I am currently a doctoral student in health sciences with trauma-informed care as a cognate, and I am at Liberty University. Today I'm going to go through a very important topic, not only through the lens of PTSD, but an excellent treatment that has come out and proven very helpful for PTSD. So I want to go through today for you just a deep dive into prolonged exposure as an excellent treatment modality for PTSD. I'm going to walk you through the process of PE after defining both PTSD and PE, as well as who it benefits, a specific population that prolonged exposure can help. I'm also going to give you just a fictitious example, but it really will highlight how prolonged exposure can be used. And again, look at some spiritual considerations and outlook. On a side note, I am not an experienced or licensed counselor. PTSD is defined right now as something that happens after a traumatic event has happened in someone's life. The key, though, is how that person processes that traumatic event. When they begin to have symptoms such as anxiety, waking up in the middle of the night with nightmares, re-experiencing the entire event over and over, known as a flashback, extreme fear or phobias that have developed following the event, and depression. And those things begin 30 days or more after the event as part of the criteria for defining PTSD as a diagnosis. Again, those symptoms can last longer, not only than just 1 month, they can actually go on for years if they are not addressed or healed. PTSD is significant in that it has affected close to 9% of the general population, and that's just at the reported level. And again, there's even groups that see this at a greater rate, which I will get into on the next slide. So one of those rates that I mentioned that's greater is in the 25% of all soldiers. So war veterans have reported PTSD at much higher levels than 9%. Those could be people that are returning from war, but also those that have served in any capacity in the military, but experienced any kind of trauma for what they saw, heard, or felt that their life was in danger. Over $200 billion has been spent on all of the impact that PTSD causes. So whether that's in the mental health space, physiological health needs, medications, therapy, etc. It does affect people's ability to remain employed, so those dollars are also impacted on people's personal finances. There are other comorbid conditions that arise as well, things such as even there's literature pointing to just heart issues and also increased suicide, as well as ER admissions for the things that I just mentioned. Just overall, decreased health has been found in the literature cited on this slide that is basically goes along with PTSD. So again, I want to focus on the empirically proven therapies that really help people fully recover from PTSD. And so the ones selected for today's lecture to just dive into to really understand it start to finish is from a leading expert in the PTSD field from FOA, and we're going to dive into prolonged exposure. This is a treatment that has some of the longest research, over 3 decades of research, data, evidence, really proving that this can help people with PTSD that either are coming to treatment for the first time or have tried other treatments that failed. One of the key parts of prolonged exposure is the foundation of where it came from. So it actually stemmed out of the emotional processing theory, and this is incredibly important to understand because, again, the subject matter expert on this Edna Foa and her colleague Michael Kozak used this as their basis to go on to develop prolonged exposure and wrote the manual on it as well. So the basis for this theory is the concept that someone who has PTSD must work through the process at the emotional level. Again, the key being the emotional level. It's not simply through cognition or behavior changes, but actually to face the emotions tied to the memories of the event. And again, that makes it different than some other PTSD therapies. So I think beyond defining it, it would be helpful if I explain this through a real life example of how the emotional processing theory works. So let's take, for example, a natural disaster. Natural disasters are certainly a cause for some people to experience PTSD later on. Not everyone will experience PTSD from natural disasters, but I wanted to use this example of a tornado related to the theory again. So the theory is looking at how we use fear for protection. So for example, a tornado is literally coming at someone's community. And so that fear causes them to have hormone responses, physiological responses, and they are able to then go shelter in place from a tornado. So, however, the issue arises when that fear response turns on for all future wind, basic thunderstorms, or just even hearing that there is a storm arriving can evoke the same series of fear-based emotions that then have downstream physiological effects. So the post-traumatic situation after a tornado is survived is that they are now triggered to have this fear to all weather-related events. So for example, the behavior that would be seen following that is that because of their emotions and how they emotionally processed this event, they feel vulnerable to a tornado at any given moment, even when there is not a threat of one. So they do things such as suddenly they have a fear of driving places or fear of being out at an event that they can't predict if the weather is going to suddenly turn severe, so they stop going to social events. And again, whether real or imagined, it has changed their entire quality of life. So the emotional processing theory talks about how this begins and how it morphs into long-standing symptoms. So in taking that, the prolonged exposure therapy, then it informs the outcomes of how this actual treatment can really work and help. Because again, if you have people that need to be reprogrammed to not attach fear to all wind and all storms in the tornado example, then they're able to no longer have the response that has been programmed to occur in numerous settings, even without a real threat. So we're going to dive into how this is actually possible. And again, this emotional processing theory being the foundation of prolonged exposure. So what does the time commitment of prolonged exposure look like? The sessions total with the therapist, and again, it's an approximate 11 sessions. In FOA's handbook, she discusses that, or in her textbook, 8 to 15 sessions. So again, it can be something that goes shorter or longer, and again, this will be client dependent, but you really want to count on spending a good hour and a half every session with your client who has PTSD coming to you for prolonged exposure therapy. All right, so we're going to dive into what occurs in the sessions that makes prolonged exposure so successful. So again, I mentioned that the sessions can be as few as 8 and up to 15 or more. This is very impressive because it really means that a client can see real turnaround in as few as 2 months and only coming twice a week, for example. But how does that first session really begin? So one of the key aspects of the first session is education. You want to explain to them, what is prolonged exposure? But even before that, it could be important to really dive into, what is PTSD? What are the symptoms? Even showing them a visual of what the symptoms look like so that they can find their own symptoms in that list and realize that's what they've been experiencing, as well as explain that prolonged exposure is backed by 30 years of research. And again, the exposure to the trauma and even discussing it, facing it, actually will lessen the symptoms. So this is how you really want to start PE with your client. So an important aspect of this first PE session, though, do not forget the importance of trust building, because again, you're going to be walking with this client for the next couple or even several months, depending on how they progress. So you want to let them know that you not only are trained in this and understand this, but you're committed to walking through this. Again, this is a data-proven therapy. It has been shown to have some of the top outcomes in the PTSD treatment literature. Again, the main goal of prolonged exposure is to face what has been going on in one's emotional processing. So one of the things that Edna Foa really focused on is this concept. And so I'm calling it avoid the avoidance. So Foa talks about avoidance is actually worse for PTSD. People think if they ignore their trauma or don't face the emotions that stemmed from it, that they will heal and do better. But actually, the literature says otherwise. The data shows that when you do not think or work through the emotions of the traumatic memories and the reactions that have been occurring to those memories, the PTSD symptoms can go on to last longer and be more chronic, years, for example, instead of simply months after the event. So again, avoid avoidance could be a phrase that you could provide your client. Then moving to that next session, something called in vivo. So this is a very famous part of prolonged exposure. And this is actually something where you're going to begin to discuss with them homework. So in vivo, think about in real life. So this is real life exposure to those triggers, places, people, things that they have been avoiding that reminded them of that traumatic event. So it could be something where you are going to walk through making sure that they have identified their traumatic event clearly, and then what are the things, the scenarios that they have been avoiding that causes them to have distress or feel like their PTSD will be heightened if they face it. So this could be something as simple as they used to drive their car, but now they're afraid to drive following a car accident. So an in vivo exposure would be going and being able to just go sit in the car, don't even turn it on. And it's going to be something that's going to give them the ability to start to slowly face the things they've been avoiding. That has, again, changed their quality of life in a negative way. One of the important things here, too, that the literature talks about is using the shared decision-making model. In other words, you're going to talk through what exactly would be the best in vivo homework for them. So we talked about they could go sit in a car, but perhaps they first need to even just start with being able to go outside. Maybe they've been avoiding going outdoors altogether. They can't even make it over to their car. So that is, again, where decision making with the therapist and the client together is very important. And again, reminding that client how exposure is really going to help their symptoms if they will stay committed and really give this a good try. So just some more examples. I think this is a great picture because this woman maybe has dealt with a certain traumatic event in her past, and it does not have to be related to a grocery store, but maybe because of the traumatic event, she's afraid to go to the grocery store. Maybe it's because of being around people. Maybe it's the sounds, the smells at a grocery store that remind her of the traumatic event she experienced. I also like this picture because she's wearing a watch. So one of the things with in vivo homework is it's going to be in small increments of time starting out. So we talked about the driving or sitting in the car example, but it could also be just driving down the street and back home daily if the fear has become driving. Going to the parking lot of a school or office building where violence maybe occurred that was traumatic for someone. Maybe outside of this grocery store, she started first in her in vivo homework by just parking at the store weekly, sitting in the parking lot and setting a timer, sitting there for 10 minutes. And then eventually her in vivo homework transfers over to going inside. And then she sets a timer for 5-minute intervals inside the grocery store. So again, these are examples of in vivo homework where you have a specific task that is enabling someone to face a traumatic trigger, and it's done in intervals of time that are helpful and not distressing. So in other words, you're not going to have them go to the grocery store for one whole hour their very first time, right? So you're going to build up to those time lengths as well. So the third component of imaginal exposure, or forgive me, of prolonged exposure is the imaginal exposure. This is incredibly important, and this is perhaps what people might think more about what therapy is where you are sitting and you're going back through the event. But this is different than simply your cognition, again, emotional level processing. So one of the key aspects of this is going to be a recorded session. And the recorded concept is very critical because the patient will get to take that recording home. And what's going to happen is they're actually going to be given imaginal homework and be told to listen to that recording daily. The client will recount what happened, realize they're making sense of the traumatic event. They're going to actually walk through that event of that day. And again, this is where education will come back into play with your client. This is not to cause more trauma. In fact, it will actually help them in the end and be a very key part of their healing from PTSD if they will walk through the emotions of that day or of that moment and then record that and go home and listen to it daily. It gives them the ability to hear the story and realize where they are now, that they're removed from it. And again, this part of the session is critical, and you really want to plan for at least half of those 90 minutes need to be dedicated to imaginal exposure. So out of this third session, a key takeaway for imaginal exposure part of the PE therapy is that reminding them that recounting the events of the trauma does not actually mean that they are repeating them. It is not causing them to be re-traumatized. Now, while this is a difficult part of the healing and of the therapy, it is not harmful. So while initially that imaginal discussion is going to involve those high emotions, we're really going to gain traction in PTSD healing by doing so. And again, listening to that recorded session at home will really help the clients to hear their own story. And it's through their own voice. And this helps to reframe the entire event and realize that the threat has been removed. Another key aspect of prolonged exposure is something known as the subjective unit of discomfort scale, also known as SUDS. So here in this picture, you have someone who is distressed, right, or needing to to kind of step away from something that is distressing. And so this is a scale where clients will be taught how to use it while reviewing their homework. And they will do this aloud with you. So the scale is very basic in that it is a 0 to 100. If you think about 0 being nothing and 100 being everything. So again, the 0 being activity in their homework. So in that, going to the grocery store, or going to see a movie with friends, or going to a crowded concert even. Is that a 0 for someone, a 50, 70, 100? And again, that 100 being the worst discomfort since that traumatic event. So you're going to, when you are reviewing the homework with them, go through the SUDS and ask them, okay, so when you drove your car down to the street stop sign and came right back to your driveway, what would you rank that in terms of level of discomfort? So over time, those rankings, obviously, you want to see those drop for that client. You want to see that 90, that 80, that 70 start to become a 10, 20, etc. All right, so one of the other things to really dive into later on as the sessions progress is something known as hotspots. Experts call these a hotspot because they are areas of the memory where they are still causing distress, but maybe the client hasn't wanted to speak about it. Maybe they haven't really realized it was something causing them distress. And so these are the focus areas of subsequent sessions when the client has started in on the, with the in vivo and the imaginal exposure homework. And the way to do this to really find those hotspots is if they're not making progress, for example, on their SUDS rankings, or they're not able to go to the grocery store longer than 1 minute. Encourage the client to embrace, maybe there's some more deep-rooted memories, or maybe they haven't fully spoken about all of the aspects of the traumatic event. So helping them identify those, again, helps them to avoid avoidance. All right, so finally, when you approach the last session with the client, so this could be, for example, session number 10. Again, for some, it could be session 15. Once you know that they are at a better place with their SUDS rankings, with their success in the in vivo homework, their outings, their ability to be in certain settings, again, their quality of life improving, you want to have a final session with this client. Again, it can vary, but this is going to be that they're going to retell that traumatic event one final time aloud with the therapist. They're going to review that homework one more time of the most recent, both in vivo and the imaginal. And this is really a celebratory session because you're going to be ending this 90-minute time together, but really reflecting over the last couple of months. You're going to be able to help them see now you can actually go travel. You can go and return to work. You can go see people that maybe you were once afraid to see. So again, things that once were a distressor are no longer such a fear factor, and their emotions are able to process things different because they've been able to reprogram that fear processing that was going on prior to starting therapy. Just want to go over that this is a recap of the PE sessions. Right here, I thought I built this chart to give you a good resource to understand the PE session type and when it's initiated. Now, these are not session numbers in the sense that you only do them in those sessions, but rather when do you start adding that part of PE? So when do you start adding the in vivo, the imaginal, and then again what the client will experience in those sessions. So I've gone through here from education all the way to that final session of over 9 sessions. But again, that education session, you're going to be educating your client throughout the entire process, of course, but certainly the initiation number has been put here in that second column. So I hope you find this to be a helpful resource to break down when to start each PE session type and what the client will experience in summary. So again, we want to make sure we understand, so who benefits from PE? We mentioned obviously the PTSD diagnosis, but does it only benefit one type of person? The answer is no. It actually, it has been helpful for people all over the globe. The literature actually shows this helping in numerous countries, from war-torn countries to other natural disasters all over the world and other traumatic events, populations, ages, and genders. People also that have not had success with other treatments, including the use of medications, have actually found prolonged exposure to work. So in that same token, who it should not be used for would be if the client cannot name or remember the actual traumatic event. So let me explain this a little more. Basically, if someone comes to you and says, I've had a lot of trauma in my past, I want to use prolonged exposure, and you ask them to really be able to name or describe what trauma occurred, and they can't. They can just say, I had a traumatic, 4 years when I was overseas, but they aren't able to tell you a specific event. That is key to prolonged exposure, because you're going to focus on a specific event in time. If the client is harming themselves, then it is not the time to start with PE. They first may need some other treatment, medical treatment, or other treatment modality prior to starting PE. Now, formerly, it used to be thought that clients who were overusing alcohol or even drugs may not have been recommended for prolonged exposure. That recommendation has changed per our text from FOA. So now they can concurrently actually be in a place where they are addressing the alcohol use as well as prolonged exposure therapy going on at the same time. And they have seen success with that. So I want to dive into a specific population PE can help, which is women who have PTSD from reproductive trauma. So again, remember that PTSD, that definition at the beginning of this presentation. So you want to take those same symptoms and apply them to a specific population of women who have gone through any kind of traumatic experience related to having children. So, for example, women all around the world that have experienced miscarriage or traumatic delivery, where they had maybe even a near-death experience of either themselves, the baby, or both. Maybe they actually lost that baby at birth, known as a stillbirth. Maybe they were diagnosed with infertility and told they could never have children. This can be a very traumatic diagnosis. Maybe they've had an abortion and had post-abortive PTSD. So this is really an example of an application of PE that is important to think about, because it affects a woman in her ability to have relationships, go on to have future children, how she is able to interact in society, in her own family. And so this is a population of interest that could really benefit from prolonged exposure. So we're going to use an example of how you would apply PE to someone with reproductive trauma. So this client, we'll call her Jill. She is a 30-year-old woman, married, and works as an accountant at a local hospital. She does have a history of that very difficult diagnosis of infertility, but finally conceived after 5 years. Jill did not have any complications in the pregnancy. At her final prenatal visit, however, so when she was nearing term, her OBGYN had concerns enough to tell her, you need to go immediately to the hospital. And then upon arrival at labor and delivery, Jill was told that her baby no longer had a heartbeat, and she still had to deliver that child who was not living at birth. So Jill's current symptoms is that she is unable to go back to work at that hospital. Again, she delivered the baby at the hospital she works at. She has insomnia, anxiety every morning with the feeling of her heart racing. She keeps replaying the scene of the hospital delivery room in her mind. She's having nightmares when she does fall asleep, awakens screaming, and she is startled by beeping sounds, anything that has those same noises of a hospital room or monitors. So Jill was sent by her OBGYN for counseling after being cleared medically. And Jill may be experiencing normal grief, certainly amidst such an unexpected loss of this baby she had so long desired to have. However, the research actually came out of Bottomley et al. Has shown that in these types of sudden cases where they have a sudden tragic loss of a life, of someone close to them, they actually can have PTSD amidst normal grief. So Jill is needing to make decision of how to move forward, and she is supported by her husband, which is important to note, who is concerned about her symptoms, and she does agree to prolonged exposure therapy. So again, how would you approach PE with Jill? You would use those same session examples we talked through, where you're going to review her PTSD symptoms, help her understand what PTSD is and what it looks like. You're going to explain to her how PE works to lessen the symptoms. And don't forget the ever important building of trust. And again, really walking her through why avoiding avoidance will help her in the long run. So you're going to discuss that in vivo homework. Perhaps the shared decision making you will do with Jill will involve talking through driving to the hospital where she works, and it's also the hospital she delivered the baby at, and just simply sitting in her car there. Maybe once she's able to do this for extended amount of time, she will eventually be able to start to get out of the car. Maybe go sit on a bench outside of the front of the hospital. And again, these will be done in timed increments. For her in vivo homework, you're gonna that would be really focused on her ability to return to work. But in her imaginal homework, which starts in session 3, you're gonna have Jill record that story, record really the day about when she was told her baby didn't have a heartbeat, and also that was the same day that her baby had passed away. So you want to explain how she will listen to that recording at home and again daily. You're going to help identify those hot spots with her. Maybe by that 4th session, it's going to be time to start to really describe more about what she saw in the hospital room, for example, what she heard, what she experienced. Walk through more of that timeline. Where was her husband? Who was around? You're going to also walk through the SUDS for Jill, have her identify what was it like to go to the hospital for the first time since her delivery in her car. How did driving there go? How did sitting in the parking lot or parking in the parking deck at all? How does she rank that? And so, for example, if she really found that entire first drive there or even parking there very distressing, Jill might have ranked that as a 95. If you were listening to her record, or if she was listening to the recorded session, she might have ranked that as a 70. Whereas going to bed at night, even though she's having those nightmares, she doesn't rank that as high of a distressor as actually having to return and face the hospital. So in that final session for Jill, after completing roughly 8 or 9 plus sessions, you're going to really have Jill tell that traumatic event of her stillbirth one more time. You're going to review that important homework and then how she is now able to finally return to work, how she's able to finally have 7 straight hours of rest, for example, without the nightmares. So I really like this picture because it shows the actual stars of building upon wins along the way in prolonged exposure. And here are 9 stars. So that really also helps you remember after completing those 9 sessions, you will typically be able to find that final session time does make sense. So really quick, just the spiritual considerations. Clients may want to share their spiritual beliefs or not at all during PE. Certainly people can bring their faith into those sessions, and certainly their faith can be affected by PTSD. Clients may even have an increase in their faith after PE as they heal. They may have questions. They may want to deep dive into that. And this is an area where even Bottomley et al. Describes in the literature, clients, may want to have more of a relationship with God, or have struggled with that based on their trauma. So in the future, one of the areas that PE could continue to be a focus for is for veterans. Veterans still do not have the same level of successful response as civilian clients. So the research definitely needs to increase in that area. How can we help veterans to have more success in prolonged exposure? More research is also needed of when and how to utilize PE in special populations. So I gave just an example of one such population as women who've had reproductive trauma, but certainly there's other groups of populations where this could be studied more and see if it really helps certain types of trauma over others. There are some challenges of PE just to keep in mind, just that compliance of actually completing it. That can be through attendance or other factors, maybe challenges with schedule, logistics, etc. Maybe the cost of the counseling, and also the access, finding counselors who are trained in prolonged exposure. They may live in an area where there is not one, so that can be a challenge with PE. Finally, why prolonged exposure was selected. It works. It is absolutely one of the best therapies in the literature. It has one of the highest success rates, and it also has over 3 decades of data. So notice in this picture, the client is standing in a crowd with confidence and joy. This is such a testament to the effects of prolonged exposure. Thank you for your attention. Again, the client in this presentation was purely fictional, and the pictures and icons used have been noted here. Thank you for your attention. This has been a privilege to walk through such an impactful therapy that hopefully can help many more people in the future. I've included my references. Thank you.